Hey everyone, Dr. Matt Geller here. We are live in our San Diego office, just about finishing up Eyes on Glaucoma. I hope you have had an amazing show so far. Keep in mind, after this last interview here, we will do some closing thoughts. You know, we like to spray confetti all over this place if you've been to one of our previous shows, so do stick around. My next guest is a member of our editorial board, Nimesh Patel, Dr. Nimesh Patel. Let's bring him on. Hey man, how are you?
Hey, Matt, how are you? Thank you for having me, and welcome to everybody there. I'm glad to be here today.
Yeah, absolutely. No, it's a pleasure to have you. Today we're talking management in glaucoma, but first, just give a background for those watching, a little bit about you, some of your training, and that sort of thing.
Yeah, so I'm an ophthalmologist. I'm at Massachusetts Eye and Ear Infirmary in academic practice as part of the Harvard Medical School, and I did my residency and fellowship training at Bascom Palmer in Miami. So I'm just 1 year out, so some of these things I'm still learning as well, but hopefully I can share my experience.
Yeah, no, absolutely. So first one here, your approach to a new patient that walks in with high pressure, what are the first things that are going through your mind?
Well, the first thing I always think is real. There are so many times when the tono pen is not calibrated correctly, the patient is squeezing. So I always recheck the pressure and even use a different instrument or method, maybe applanation, to check the pressure. If the pressure is relatively within a normal limit, just maybe a little bit over 25, 26, I'll often bring the patient back just to make sure there wasn't some caffeine or another environmental factor that could have raised the pressure, and really just to make sure, does this patient truly have elevated pressure? It doesn't have to be decided on one day. um, of course, if you do see a patient that truly does have high pressure, the first thing I would do is do a gonioscopy. The first thing you want to make sure is there's no angle closure, chronic or acute, that requires an intervention right away.
Yeah, no, absolutely. It's a critical piece, and I like that you're filtering out some of those kind of lesser known things. I think we actually just published a piece on the foods you should avoid if you have glaucoma, and so I don't know if you're running through that list in particular, but I guess it is important to cover those bases there, pretty immediately upon finding something like that. Diagnostics has been a huge topic of the show over the last 2 days. And not everyone's good at grabbing a good image. Any pearls on diagnostic imaging in general, when it comes to the management of glaucoma?
Yeah, well, I'd first say the key is actually a good exam of the rest of the eye. There's a lot of secondary causes of glaucoma that you want to rule out. A typical one I see is inflammation. You can have subtle uveitic glaucoma, also bleeding, choroidals causing posterior pressure. So first thing you want to do is, after you've ruled out angle closure, make sure you dilate the patient and look for anything else that could be causing it. Now, then if you go to the imaging, it's a very similar approach I have to the pressure, where you want to make sure that the testing is reliable first. So most often you're starting with a visual field and an optical coherence tomography of the nerve fiber layer. And if you go with a visual field, it's important to look at the reliability. Usually for things like fixation losses, false positive, false negatives, we're looking for anything at least under 30% for those numbers. And you kind of take the whole test as it goes. One pearl for the visual field is often to repeat it. There's usually a learning effect, especially if you see the left eye is better than the right eye and the exam looks normal or equivalent. Sometimes there is a learning effect. So what I'll usually do is bring the patient back within 2 to 3 weeks, get a second visual field, and call that their baseline, rather than just going off the first test. In terms of the OCT RNFL, one pearl I would say is these don't have to be done on the same day. Depending on your practice setting, the visual field may be in a different location. The OCT, the patient may have been there for a while already. The visual field is undilated. The OCT may be dilated. So I usually will also split those up on different. There's no harm in bringing the patient back to get those tests. The one thing I would really stress about the OCT RNFL, we get very caught up in the readout, especially on the Cirrus machine, looking at the green, the red, and the yellow as glaucoma or no glaucoma. And there's a lot of things on those tests that can give you false positives or negatives. The one I see a lot is swelling in the retina that can increase the thickness of the ganglion cell layer, and the nerve fiber layer still may be thin. And on the on the readout, it would say green, but the patient does actually still have glaucoma. So if the testing is not in line with your clinical suspicion, make sure you're going back to that test and really looking to see if it's accurate.
Yeah, it's pretty easy to get stuck. You've got a high volume environment and you're just like, all right, what color is it? Is the visual field, what's the pattern look like? And you're not looking deep enough into some of the analytics that come from it. So I do appreciate those. And yeah, the learning effect on visual fields is a critical piece. And I think it's like, oh, I don't want to burden the patient. They got to come back. It's already, a slow enough test. Although Zeiss's CETA faster is pretty fast, but no matter what, you get an older glaucomatous patient, could be annoying for them, but you've got to do what's right in getting that baseline because everything will be based off of it after there, of course. When thinking about topical meds, side effects, what are some things to consider there, and what has your training taught you?
Well, I have one interesting, funny story that one of my most unhappy patients was a patient who came in with high pressure, and we cured them with a topical drop, and I was very satisfied. And they came into the room after I saw that the pressure was down, and I was ready to give them the good news. However, they were very upset because their eye color changed, and that is from lotanoprost, the prostaglandin darken the eye color. And I think in terms of the side effects for all the medicines, we usually think of that one as an afterthought, but I have heard that from a few colleagues that you have to really watch out for the eye color change, particularly for light colored eyes, people who value their cosmetics. So think about that one hard with latanoprost. Additionally, with that one, I also see a lot of patients with cystoid macular edema. And if you have diabetic edema or diabetic patients, maybe latanoprost is not the best first option because it can worsen the macular edema. The other ones you have to think about is timolol with heart block, especially if a patient walks in with acutely very high pressure and you're going to give them a few rounds of drops within a short amount of time. That timolol can actually induce a heart block if there's a patient with an underlying predisposition. Another one is the dorzolamide or the carbonic anhydrase inhibitors. There's a few side effects to look out with that one. Number one is if you get a patient with sickle cell disease who may have high pressure from neovascular glaucoma, the dorzolamide, both the oral and the topical, can induce sickling. And the other thing is in kidney disease, especially if you have a patient that walks in with a pressure of 50 and your first instinct is to give them orals as well, make sure you're asking about kidney disease because that can worsen that as well. A few of the newer ones that we may not know as much about is Ropressa. So this is another class of medications that can be used for glaucoma, but some of the patients I'm seeing are starting to have corneal changes. Now, they're usually not overly visually significant, and they do get better over time. But if you see a patient that has corneal changes after you started Ropressa, just keep in mind that that one is probably the cause.
Yeah, I love this list. I mean, it's kind of been a while and you forget some of these. You learn them and they don't show up too often, but those are super, super critical ones you have to remember. And I like that you went for kind of the heavy hitters, the ones that you really have to look out for, or else you cause some major issues. Laser treatment has been a huge topic. I think I've done 3 different interviews on SLT today. We've got a bunch of cool survey data around laser treatment in glaucoma. Would love to hear your take on it.
Well, there's a couple different lasers. There's the SLT, but also the laser iridoplasty. So I'd start with SLT. I think in the past, there has been more of a push that it's a second line. So you start with drops and then goes to laser. And I think that's really changing, particularly because in the days of ALT, there was a little more side effects in terms of pressure and inflammation that can be caused. Or with the selective lasers, they don't have these same side effects and they're extremely safe. So I often actually will offer those to patients as a first line. I think some people don't do that because it can slow down the clinic, it adds more time. But again, you can bring them back for it. So I usually will offer SLT as a first line, mainly to see if we can stop. We don't have to put them on drops right away. I'll usually do 180 degrees, see them back in 1 month. You have to give it about 2 months to see if there's an effect. But I think laser it's not necessarily you try drops first and you go to laser second. I think that you can have that conversation, drops or lasers, right at the beginning. So I really like SLT as a first line. Another thing to know about the laser peripheral aeroplasty for angle closure. So it doesn't work that well in chronic angle closure patients. So you want to do a good gonioscopy, and if the angles are already zippered shut, there's no real benefit in doing the LPI, or if the patient is pseudophakic. So then you're thinking about other treatment options, beta blockers. The other thing about the LPI, I do see a lot of patients getting LPI'd for just narrow angles, and there is the EAGLE study that showed that early cataract surgery can be relatively equivalent to the LPI. So it's something to think about if they have a mild cataract and angle closure, that cataract surgery may do the trick just as well as an LPI.
Yeah, I was interviewing Nate Radcliffe before, and we were talking about the LIGHT study and using SLT first, which was super insightful for all those listening. Do give that one a look. I can't remember the one-liner he had that was good, something about how laser doesn't forget to put its drops in or something like that. But that is definitely, I think, one of the trends I've picked up on the most is just starting with laser. It makes a lot of sense. And then, of course, MIGS as a primary line of therapy, and there's been some interesting talks around that over the last 2 days. So obviously you're focused most on retina. Dr. Amar was just on, also focused on retina. We dug into all sorts of really cool things there. So in particular, when should you consider a referral to a specialist, and why? And how might this relate to the retina doctor's kind of line of care?
Yeah, you'd actually be surprised how much glaucoma I manage. It's always a running joke I have with the fellows that you can never run away from glaucoma. Part of the reason is just today's world is not easy. Everyone's very busy. It's difficult to get a patient in to see a glaucoma specialist. So number one is to really know management and treatment, because you'll be managing more than you think. The other thing is to actually have a glaucoma friend on cell phone, on text. When I put referrals in the system, it can take 1 month or two. You call an office. Oftentimes, I'll see the patient back for their retina issue a second time before they've gotten in with glaucoma. So I would suggest finding a friend that you can really text and know that patient is going to get in. So that's number one. In terms of when I refer for patients that I think are going to need continuous monitoring, shorter than a few months duration. And mainly I refer patients towards surgery. So I'll usually do a lot of the drop management myself if needed, even get a few imaging tests as screening. But if I think there's a patient that needs surgery, I'll refer that patient as well. And cataracts also come into this, because now with all the new MIGS treatment, the Hydrus, the Cahook, the eye stents, there's so many of them. If you have a mild to moderate glaucoma patient who's developing a cataract, that's a good referral, because they can get the cataract and the pressure managed at the same time. Also, and it doesn't have to just be cataract surgery that they're going for. So they could be going for another surgery, even a retina surgery. So I'll have patients with silicone oil, or that I'm thinking of taking the oil out, and maybe they need a tube at the same time. Those are good patients to think about trying to get everything done in one surgery.
Yeah, no, I'm glad you brought up the piece on cataract side of things. Any cool cases off the top of your head that you remember where you're going in for something retina, and turned out to get a pressure spike, or just anything around that general topic there? I'd be curious if you have any.
Yeah, there's actually a couple pearls about retina and glaucoma. So there's the retinal detachment. Some of those chronic patients, they actually can get low pressure, but they can get high pressure from photoreceptors clogging the trabecular meshwork. So it's important to think about that. It's called Schwartz-Matsu syndrome.
Whoa, never heard of that one.
Yes, the retina can cause glaucoma. The other thing is with silicone oil. If you have a patient with oil, sometimes those patients may be aphakic or pseudophakic, but they can get oil in the anterior chamber, and it can be a little tricky to tell. The oil is optically relatively clear. One pearl I have is look at the iris, and you can see a sheen on the iris, and that's a trick that potentially the entire anterior chamber is filled with silicone oil. And those patients aren't really good for drop management, because basically there's no way for the fluid to get out. So those are patients that may need referral for an oil exchange or something else. Another patient I see commonly with high pressure are those after cataract surgery with vitreous in the anterior chamber, post a complicated cataract surgery, or you can see them sometimes on post-op day one with a sulcus IOL. One thing to note is atropine actually is not often used, but can be a very good way to lower pressure. So sometimes you're getting pupillary block from vitreous being occluding the pupil. And I can often see, or if there's an unstable lens, basically a patient post-trauma, atropine dilating the pupil, giving more area for the aqueous to flow from the anterior to posterior, especially if vitreous is blocking, or if you have a trauma patient and the lens is moving and it's phacokinesis, atropine can help lower the pressure acutely.
These are some good pearls. I like them. I like them. Anything on the horizon that you think that you're just looking forward to that's coming out, some innovative stuff, maybe deviating even a little bit from the glaucoma topic here? Just curious. You seem to be on it.
Yeah, there's a few really interesting things coming out. I'll give you a little bit of a crossover here between retina and glaucoma. There's some new things coming out in the retina space. We do a lot of intravitreal anti-VEGF injections, and there's some companies working on implantable port delivery systems. So these are surgically implanted in the sclera, and you refill them once every 6 months with an injection, rather than giving an injection every month. And the cool thing is this can decrease your injection burden for anti-VEGF in macular degeneration and diabetic macular edema. However, the really fun thing is the technology of implantable ports. So you could potentially fill that up with a glaucoma drug or any other type of drug, maybe a steroid. So that's one thing to look out for on the horizon, is really drug delivery improvements that could allow us to give long-term treatment without need for constant drops or constant injections.
Yeah, I love it, and that's interesting because Durista has been a big talk or topic of the show, and I think we're just getting started. Would those be able to be preservative free, or would they have to have preservative, those implantables? Just curious, or to be maybe a mix.
Yeah, so the pharmaceutical companies are working around this, so they can have some different formulations that may be preservative free. Working on the non-preservative free formulations because of how fast they're being cleared from the eye, what's the concentration you need. So they're very early, but I will say the anti-VEGF ones, the preliminary trials are showing that it does work for sure. So there's a lot more in the retina space going on right now, but I'm sure that's going to transition to the glaucoma space as well.
Got it, got it. Any closing thoughts before we begin to wrap up the show?
No, that's mainly it. I hope it was helpful. I think if I could summarize this in one sentence, it would be really think about a patient coming in with high pressure. Is it really glaucoma? Send the imaging, because if you diagnose that patient with glaucoma, it really sticks on their chart for life. So I think the first step is just saying, do they really have glaucoma? Was the pressure really high? Is the test reliable? And I think that's where you have to start.
Yeah, and I think you've got time on your side there too. Obviously, unless you have a crazy elevated IOP, but you've got time on your side, and you got to think about the mental impacts too of telling a patient, "Hey, this is what you've got," and I guess it's that kind of slow down and get your diagnostic tests in order, and that's great advice. I love it for kind of closing thoughts here for sure.
Great. Well, have fun. I'll see you later.
Thanks, Dr. Patel. Much appreciated. And for all those still hanging around, we'll be doing closing thoughts in just a few. So sit tight and we'll be back. But Dr. Patel, thanks very much.